Good morning, everybody. I want to welcome you. I'm Anthony Nesburn. I am the Vice Chair for Research at the Gavin Herbert Eye Institute. The Gavin Herbert Eye Institute and the Discovery Centers for Eye Research welcome you to our 5th annual Bench to Bedside Research Symposium. It's really a pleasure to be at these meetings. Those of you that have been here before, I think, understand that it brings together thought leaders in diverse areas that have an impact on sight, and today is no exception. As you will see, we're talking about the microbiome and stem cells and models of disease, and with speakers, with keynote speakers that are really outstanding people and representatives of research from across the nation. I'd like to introduce Christina Kenny, who is the moderator of the first session. Chris?
Thank you very much, and I want to thank all of our speakers and the people attending. Our first session is Integrative Health Models for Diagnosis and Treatments. Our first speaker is going to be Dr. Barry Kuppermann, who is the Roger Steiner Endowed Professor. He's our new chairman, and we're delighted with having him. He's doing a fantastic job. As a brief history, he received his PhD in neurosciences at Caltech, then an MD at the University of Miami. He did his internship at LA County, USC Medical Center, and a residency at Doheny, and then retina fellowships in Baltimore and at UC San Diego. His research interests have been he's been involved with several multi-center national trials testing new drugs and devices for diabetic retinopathy, age-related macular degeneration, and retinitis pigmentosa. And the title of his talk is Evidence-Based Medicine, Successful Application of Randomized Clinical Trials in Assessing the Benefits of Nutraceutical and Diet in the Age-Related Eye Disease, or ARIDS study. Barry?
This talk specifically is to show ophthalmology, traditionally a very conservative field, frequently politically, maybe less so now, but also sort of just by inclination, a skeptical field, and in fact to discuss the ARED studies, which are basically a group of skeptical ophthalmologists, clinical scientists that designed a clinical trial in a certain sense largely to disprove that these vitamins would do anything to impact the course of macular degeneration, because it had become sort of a popular fiction in the eyes of the designers of this trial, that we're going to prove the folly, put the folly to rest, that vitamins could actually impact something like macular degeneration. And in fact, it was done in a very thoughtful, coherent, methodical fashion, and to everyone's amazement, showed an unequivocal benefit. So I think it's an important lesson as we move forward in this new era of integrative medicine, that we can explore the realm of integrative medicine in a thoughtful fashion, using evidence-based medicine, designing randomized controlled clinical trials in such a way that we can prove or disprove how these may work, and if they do work. I'm going to talk a little bit about some background of this disease and then get into the nitty-gritty of the trial. And the point is to really get into the nitty-gritty of the trial to show you how methodical and thoughtful it was done in a coherent fashion. But again, age-related macular degeneration, frequently known as AMD, is a leading cause of severe vision loss on people over 50 years of age in the Western world. Of course, sadly, in a lot of the developing worlds, simple things like cataracts and river blindness can become the leading causes, so those are whole other issues. There are two forms of the disease, the non-neovascular, the dry format, which which affects 80 to 90 of patients, and typically there's mild to moderate dysfunction, visual dysfunction in the early going. There's little white spots called drusen, and I'll talk about those a little bit, but they then progress to areas of confluency and degeneration called geographic atrophy, and that's where significant visual dysfunction can ensue. The wet is the neovascular, the new blood vessel formation underneath the retina, and that's been the focus of the work. And in fact, I also want to acknowledge presence of two sort of world-famous scientists we hear. I did mention earlier, but Doug Wallace will be talking in this session on integrative medicine, but also Napoleon Ferrara, who is sitting here as well. And he knows more than anybody the neovascular disease process, because he was discoverer, I think, fairly said, of VEGF, VPF to VEGF, and in fact cloned the antibody, the monoclonal antibody of Avastin, and leading to the development of Avastin and Lucentis, which are the mainstays of our therapy, and while in his role at Genentech, and then he's subsequently left Genentech, and he's now at UC San Diego, so I want to acknowledge your presence, Napo, and your incredible contribution to this field. I'd say it's unequivocal that it would be easy to point the advance in this field to, at most, two people at this level, Judah Folkman, perhaps, and Napoleon Ferrara as the two gods of this area that have completely revolutionized what we do with age-related macular degeneration and developing the treatments for wet AMD. So again, AMD is a problem. It impacts patients' lives, and there's so many studies. Again, this is the other way we can look at evidence-based medicine and integrative health, is looking at different types of analyses, value-based medicine analysis. So moderate AMD caused a 32% decrease in average patient's quality of life, similar to that associated with severe cardiac angina or a fractured hip. We know in the elderly how bad a fractured hip can be, and that downward spiral to death frequently leads to them. Severe macular degeneration has a 53% decrease in quality, more than that of dialysis, which is kind of shocking to think about that. Think of our patients, because again, retina specialists, our two main groups of patients are people with macular degeneration and people with diabetic retinopathy. So we have a host of patients that are on dialysis because they're diabetic retinopathy, and it never occurred to me that the burden of macular degeneration would even come close to that horrible burden of dialysis. And very severe macular degeneration causes a 60% decrease in a patient's quality of life, similar to that encountered with end-stage prostate cancer or catastrophic stroke. So this is a bad disease, and we need lots of therapy. And while there's good news on the wet AMD front, thanks to MAPA, and there's also good news because of this trial, which actually prevents the progression of that, we're still battling in the dry macular degeneration. We do not have therapies yet, and that'll be a subject for another day and another time, but we're struggling with that, and we're working on it, but we may have some solutions. This is what a normal retina looks like. You're just seeing a piece of it. That's the edge of the optic nerve. This is the macula or central retina, the inside backlining of the eye. And this has this is called category 1, no diffuse small drusen. And so in the study, there was a large number of people with this. Let me back up one. This is what a more drusen look like. So this is where you have actual disease state, moderate dry macular degeneration. And then it can progress. Here's the intermediate, high-risk dry macular degeneration. It can progress to two formats as it progresses. Advanced wet AMD, that's neovascularization, and I'll show you another picture, but there's blood in there. Or you can see a thinning out of the retina, this zone called atrophy, geographic atrophy. And that is the disease state for which we have no treatment. And what the bottom line is that what we need to do is intervene at this level here to stop the development of these. And with the nutraceuticals, this very coherent, thoughtful study that was done showed that if you intervene at this stage with the nutraceuticals, particularly zinc and lutein zeaxanthin, you can stop the progression to the wet form, but unfortunately we do not yet have anything that stops the progression to the geographic atrophy form. The vitamins do a little bit for that, but not enough to be considered statistically significant. And this is another view of the the advanced form, the two forms. Here you can see more clearly the blood, and perhaps here you can see better outline of the area of atrophy, where you have loss of photoreceptors in all layers of the retina. So what are the risk factors for age-related macular degeneration? Increasing age, hence the name age-related macular degeneration. Once you're 50 years of age, some would say 55, but that's the age group. There are some people that have drusen that are younger than that. That's considered a different disease, similar but different. There's another disease that's also similar but very unrelated, Stargardt's, which is more of a genetic disease that happens in typically young women or sometimes men as well in their teens. Light iris skin pigmentation. So when people ask if they're at risk, if there's a genetic risk, we say, well, the genetic risk frequently is indirect. You have genes for longevity, you have genes for pigmentation in your body. Those convey increased risk but do not guarantee the disease. Cardiovascular disease we know is a risk factor. Hypertension, smoking, the 99th or the millionth reason not to smoke. And again, it's not typically a direct hereditary disease, though more genetic associations are being discovered. If I have time at the end, I'll discuss a couple slides on that at the very end. So I want to focus on the age-related eye disease studies. So there was two of them, and the acronym is AREDS. So for those that take those vitamins, the AREDS refers to age-related eye disease study. There was the first one that showed the value of zinc and antioxidants. And then the second one that looked more carefully at a subset, because in that first study, they did a dietary nutritional intake survey, another interesting way to assess things. And they noticed that people that had large diets that had fish in it and people that had diet with lots of large leafy green vegetables, both of those two groups did better than the overall population. So they wanted to study that further based on the first study. And also there was a concern that the zinc levels, and again, I should back up to say there was a Dr. Newsom in Louisiana that was the biggest proponent of the zinc, and his patients he was giving was an 80 milligram dose of zinc that we always thought was too high because there's a risk of toxicity. So this study looked at the AREDS2 focused on reducing the zinc to see if that would change things and explore reducing beta-carotene. Beta-carotene has also historically been a concerning compound because of the risk of increased pulmonary cancer in prior smokers, which encompassed a large percentage of the population of people with macular degeneration. So those, and then we wanted to explore the lutein, zeaxanthin, and omega-3s to see if that, so that was the scenario when this study was designed. But I'll back up a bit to show some of the results from the first one to give you a context. The first one was roughly 5,000 patients. After the last patient was enrolled, and it took 2 years to enroll the patients, then they studied them for another 5 years in the first pass. So that was up to 7 years of study, but between 5 and 7 years. Then I'll show you some data from the 10-year analysis. And they were randomly assigned to either placebo, antioxidant, zinc, or antioxidant plus zinc. And again, this was the AREDS formulation. So if you go to the supermarket and buy an AREDS formulation, this was actually manufactured by Bausch & Lomb. We frequently recommend Bausch & Lomb, not that we have any proprietary, but at least this was the formulation that was actually tested. I should mention that Alcon, which is a reputable drug company, makes a formulation that's similar, but a lot of companies that in the nutraceutical thing, and that's another area of concern in nutraceuticals, when you go to Mother's Market or other places, the NEI did an analysis of some of those to see what was in them, and sadly, many of the ones, for example, that say contain lutein, either it's the completely wrong dose or there is no lutein in it. So I'm not here to malign that industry, but it's an unregulated industry. So this borders on this notion of when you're taking supplements, vitamin supplements, there is no regulation. So this is one of the rare cases. I'm a Mr. Save Money, go generic, all that. Not when it comes to this, just because there's no regulation. And there's no regulation for Alcon and Bausch & Lomb to do anything either, but they have their reputations at stake. And the hit that they would take financially if it was publicized that what they were claiming was in their compound, in their vitamins was not there, would be so large that it would not be worth it to them. So that's why it's only because of that I think, because there's this lack of regulation. But this is what the compounds were in the formulation. And again, this is the most important slide of the first AREDS study, which showed a 25% risk reduction, going from 28 down to 20% if you look at this. And again, this was the placebo arm. This is progression. You can see it goes 7 years because it was 2 years to enroll patients. So this was less densely populated, but this was a population here from 2 to 7 years that had the largest number of patients, and you can see this reduction. And it was not a big difference between the antioxidants alone, zinc, and antioxidants plus zinc. And if we go out to the 10-year mark, again, this additional 3 years, you see this continued increase in the risk reduction. This was only, though, with those categories 3 and 4. Those were those that had the intermediate drusen that I showed you in that slide, or they already had advanced in one eye and intermediate in the other eye. That's categories 3 and 4. If you look at this analysis slightly different, if you look at the odds ratios for each of the 3, for advanced macular degeneration, you can see that antioxidants, zinc, and antioxidants plus zinc all were on the left side of the line, though the zinc by itself was the least effective, but again crossed over a bit, but these two were clearly. But you can see that sadly, it was all due, it inhibited the progression of neovascular macular degeneration and did not have much impact on central geographic atrophy, the dry formulation, which is part of the natural history of this disease, and we're noticing it more and more as we're protecting our patient's sight with the life-saving, sight-saving, miraculous anti-VEGF compounds. We're protecting them from wet and the vision loss from wet, but meanwhile, the dry disease keeps chugging along, so it's becoming more and more of a problem. So we're still struggling in our lack of treatments for central GA, though you can see that maybe antioxidants had a partial effect, and I'll show you where that effect was found. Again, it crossed over, so it wasn't statistically significant, and these were clearly no different than placebo in that sense, in terms of controlling progression of central GA. So lutein and zeaxanthin, again, as well as the omega-3 long-chain fatty acids, these were observed in the nutritional intake surveys, and so they were tested in the AREDS too. Again, omega-3 fatty acids are an essential long-chain fatty acid. We need dietary intake to have them properly. Why are they important? We think it's because we know that they're a structural component of the phospholipid membranes, and so it's a stabilization of the bilipid membranes in this apoptotic space where this disease state is ongoing in the outer retina, in the photoreceptors, et cetera. It's a way to stabilize those membranes and stop them from dying so rapidly, those cells from dying so rapidly, and preserving vision is the notion behind it. And again, it's greater than 50% of the lipid in the photoreceptor membranes. What are those? So the DHA and EPA are again, it stabilizes bilipid membranes. But again, cold water fatty fish, the fattier the better. Salmon is the most popular one. For years now, for the last decade since this data came out, pretty much every retina meeting we get served salmon and spinach. That's our vitamin pills that we take. And again, it still seems, even in this era of nutraceuticals, that the best way to take that is by diet. So again, that's one of the messages, and I'll show you some of that data. And here's some of the other agents that actually are high in the omega-3s or the DHA and EPA, including walnuts, soybeans, and certainly spinach is a very popular one. Lutein and zeaxanthin is the main reason we eat a lot of the spinach. It's a natural macular pigments. Interestingly, what these do, intake of lutein and zeaxanthin, they deposit pigment in your macula. It is a little bit like internal sunglasses to protect yourself from the onslaught of sun. There's a separate study that I won't discuss, but I do recommend to my patients, which is the Chesapeake Bay Waterman study from the 70s, published out of Hopkins. Watermen, because in those days there were very few water women, but when sunlight hits when sunlight is white light made up of all the colors of the rainbow, and it's diffracted when it hits water. So when it hits the ocean, it creates rainbows. The red component penetrates into the water. The blue component bounces up into your face. So when you're on the ocean, you're in a super enriched blue light setting. And so, and we saw a preferential increase of macular degeneration there, and the best way to block blue light is wearing brown tinted sunglasses, so I do recommend that to my patients. That's the only part of my recommendation that is not based directly on the outcome of evidence-based medicine from a clinical trial, but it's inferential from the fact that blue light causes toxicity to the macula, and so you can block blue light by wearing brown tinted sunglasses, yellow, orange, or brown. But this is a little bit what lutein and zeaxanthin are doing. They're putting a little bit of a brown protection into your macula, and appears to reduce the risk of macular degeneration. So these are the foods that are rich in lutein and zeaxanthin, and again, hence the spinach favorite here in our diets. So let's talk about the study design, and I'll move through these slides a little more quickly. Again, we studied carotenoids, lutein, zeaxanthin. We looked at omega-3 long-chain polyunsaturated fatty acids. Again, the categories to enrollment, large drusen. You can see here the spots, and then geographic atrophy and neovascular. So they had to have either large drusen in both eyes or large drusen in one eye, and then this late macular degeneration in one eye. And again, this was the original AREDS formulation. I showed you the slide before, what we did for this one. All right, I'll show you separately. So we had a complex study. So that's one of the criticism of this, but it was important to really suss out all these questions. So another 4,000 patients looked at lutein, zeaxanthin, the omega-3s, and the combination of lutein, zeaxanthin plus omega-3s, and then the randomization to AREDS, either AREDS minus beta-carotene, AREDS low zinc, and AREDS minus beta-carotene and low zinc. So that was all the randomizations, two-step randomization. And this is what you ended up having. We both looked at stable doses of vitamin C, vitamin E. Beta-carotene was either 15 milligrams or 0. Zinc oxide was either 80 or 25. And we always had copper oxide, cupric oxide, because zinc depletes levels of copper. And so here was the subsequent randomization as well. So what did we see? We mostly looked at progression to macular degeneration, progression to moderate vision loss, stratified by dietary intake, time to cataract surgery. There's always a question whether this would alter the progression to cataract, which continues to be a big issue. We're still looking for cures of cataract or non-surgical interventions for cataracts, for all that the surgeries are very successful. So this is what we saw. Progression to advanced macular degeneration, lutein, zeaxanthin, favored treatment. It was a 10% reduction. The omega-3s did not help. The combination was no different than lutein alone and placebo. Here's the reference line. All right, lutein zeaxanthin versus no lutein zeaxanthin. You can see that this favors treatment. Clearly, doesn't cross over the line, whereas the other cross over the line. DHA versus no DHA, no benefit. Low zinc versus high zinc, there was no difference in beta carotene, yes or no. So we knew that beta carotene, we thought that beta carotene and zinc were important. We saw here that they were not important in that original formulation. But we did see there was a benefit from the lutein zeaxanthin. So the comparison of lutein zeaxanthin versus no lutein zeaxanthin to advanced macular degeneration, 10% additional reduction in the risk of progression. Other were not statistically significant. Again, if you look, the only place, another thing to pay attention to is what did they have from dietary intake standpoint. So those that had the least dietary intake of lutein zeaxanthin had the biggest benefit. Those that were actually eating a lot had relatively little benefit from the supplement. So it's still better to eat, have it in your diet. The more you eat in your diet, the less the vitamins are helpful. But if you're not taking in your diet, there's a lot of people that can't or won't, then the supplements really do help them. And that showed up consistently. Again, if you look at the lowest quintile, it was a 26 reduction in risk. Those that had the lowest quintile of dietary intake. If you look at progression in neovascular AMD or central GA, explored with lutein zeaxanthin, again, it favored advanced macular degeneration of all types. It favored lutein zeaxanthin. Neovascular was where the money was. There was maybe an effect there, but it was not statistically significant. So that summary here is a 10% reduction there, 11% reduction with neovascular AMD, and not statistically significant for central geographic atrophy. So what about beta carotene? Sorry, again, you can see with beta carotene and without beta carotene, but with lutein zeaxanthin, there was a benefit seen. And you can see here that this favors AREDS minus beta carotene as long as you add the lutein zeaxanthin here compared to, but no impact on central geographic atrophy. So let's look at cataract surgery. There was no impact at all on progression to cataract. In this setting, with one caveat, if you looked at those with the lowest quintile of lutein zeaxanthin intake compared to the highest quintile of intake, dietary intake, there was a decreased risk of cataract. So those that eat more of this seem to have a less risk of cataract development. And again, safety we always look at. There was no change in mortality, which is interesting because beta carotene, as I mentioned, has a risk for pulmonary cancer. So analyses were also conducted in non-smokers or former smokers for lung cancer. And all active smokers were excluded from the study, I should mention. So here you can see from beta carotene, there was an increased risk that was statistically significant, even in this relatively small study of 4,000 patients. So again, increased risk of lung cancer with beta carotene corroborating that finding, but not with lutein zeaxanthin. So again, the competitive absorption of carotenoids, just to mention another reason not to have beta carotene, it turns out that beta carotene competes with absorption of lutein. And so all the more, since we know lutein is beneficial, beta carotene has no benefit, and it could be harmful in prior smokers. That's another reason to exclude it. So ultimately, again, there is a complex study design, and so there's a low attrition rate. There's a lot of pros and cons of this study, but it was done very coherently and consistently. Good adherence to treatment regimen, and they tested patients' blood serum levels to confirm that. So to conclude, the addition of lutein zeaxanthin did not have an effect on cataract progression or cataract surgery, and maybe it did in people with low dietary intake if they supplement. And the 3 active arms did not significantly reduce the risk of progression to AMD, but the addition of the lutein zeaxanthin did decrease the risk. So there was no main efficacy of the omega-3 fatty acids. So let me just go to I just want to, considering the totality of evidence here we have it, lutein zeaxanthin is an appropriate carotenoid substitution for beta carotene, and so what's being recommended now is this formulation. This is what's in the AREDS 2 formulation. Vitamin C, vitamin E, lutein, with beta carotene removed. Zinc is still in there, but again, we think that there's some formulations out there that reduce the zinc to 25 milligrams. Most of us recommend that. Copper should still be in there, but the omega-3 fatty acids, we recommend people have it in their diet, but not necessarily in the vitamin supplementation. And I think that's another field of controversy. I think omega-3s, even in cardiac disease, are being looked at as whether they're valuable or not. So I'd like to conclude here, but to show you the details that involved in this dense clinical trial with multiple randomization steps, 4,000 patients. But at the end of the day, we learned a tremendous amount, and I think this is, again, we'd like to thank all the taxpayers, because this was an NEI-sponsored trial run and conducted by clinicians across the country, and again, with this dramatic benefit showing that nutraceuticals, when properly administered, can be of great benefit to our patients. Thank you very much for your attention. Right, I mean, it's interesting that in the nutritional intake survey, in the AREDS 1, there was a marked reduction in risk. It was a 25% risk reduction from that alone. And yet we didn't see it in the supplements. And the question is it because the supplements did not really properly mirror what happens in natural dietary intake? And that was one question. The trouble is, you saw how complex the study was already to further randomize, even with 4,000 patients in that clearly an expensive trial, to further lose statistical significance and power was a challenge. But it might be, there should be an explanation somewhere in there. But again, based on that, whatever was chosen in that ratio of the DHA to EPA in the formulation did not have a benefit. And it might be that explanation or it might be others. No, that has not been done. There's certainly analyses done on for example, the Blue Mountain Eye study and the Beaver Dam study. There's what have looked at light pigmentation and risk for macular degeneration, but not the protective risk of using lutein in the early going for that. That's a good question. There have been small studies, but not enough have to really give an analysis. But the question amongst that is, should people that have inherent risk, and I didn't get into, there's a whole other talk on genetic analysis, but there are some genes, ARMS2 is one of those, coupled factor H is another one that may convey a risk for macular degeneration, and there's a controversy that's brewing between the NEI, and Emily Chu leads the charge on that one, and then the clinical community, and there's really kind of a company involved that is a gene testing company, Macular Risk. And the Macular Risk Company, the more commercial group, says that if you do genetic testing, you can show subset analyses that show that there is, and you could do actually selective use of the antioxidants and lutein and zinc. In fact, there are some groups they say it increases the risk if you take it, and others that decreases the risk. But the NEI has looked at that data, has done their own analyses, and said there is no differentiation. And then there's a paper that shows outside groups, 3 other outside groups have looked at it, also showing no difference. But it's still an open question. Should we be doing genetic testing on our patients? That's not paid for by insurers, so that's one of the problems. They have to pay out of pocket. But will that help guide therapy? And that's the other unknown. Paul Bernstein at Utah Moran Eye Center does a lot of work on that. I was just with him at a meeting in Tel Aviv, actually, and we had a long talk about that. I have some slides about that. We can measure it, but we're not sure of the significance and whether should that encourage us to have people eat more, take more lutein or eat more dark leafy green vegetables to get that density. There's a lot of evidence, Paul in particular and others have shown that the pigment density in the macular pigment density does seem to reduce risk. So it seems a natural thing to do, but it's not been directly correlated or tested. We think that that's the reason why it works, but that's an inferential assumption rather than a direct correlation that we've been able to test and improve on a hypothesis-driven basis. Thanks very much.